Ok. ¿En español se escucha bien? ¿En español se escucha bien? Sí. Ya se conectó.
¿Quién se conectó? A mí me parece aquí 43, pero me parece solo esto.
Sí, porque esos son los panelistas, somos nosotros. Esos son los participantes, son las personas que están viendo.
Ya que si no, no tenés que alterar el programa. ¿Qué te dice cosa?
Les mandé los correos, no deben estar abriendo.
Que ya son las 7 ya. ¿Y tú tienes allá, puedes ver a los otros?
Sí se escucha.
Hello. Hello.
Ahí está el doctor Pozniak.
Hello, it's Dr. Pozniak. Yeah, how are you? Can you hear me? Hello, can you hear me?
Sí se escucha.
Oh yeah, it's taken me half an hour to get in because the link was expired.
Yes. I just
And
sent
I
to
sent
you a
several
new one.
emails, and
Okay.
then after that, the link only gave me as like I was watching the videos. And then finally, I've just got a link a minute ago to get in. So I'm in.
Okay, anyway, I send you a new one.
Yeah.
We're going to start now. Okay, thank you. Thank you and welcome, Anton.
Okay, thanks. I'm all ready. Oh, by the way, are you doing my slides or am I doing my slides?
Yes, we have your slides here. Yes.
But do I move them or are you moving them?
No, I think we are going to do that.
Okay. Great. Really good to be here. Yeah. I can hear you very clearly. Yeah. Okay. Yeah. The host did it. When I'm speaking, though, I won't hear Spanish. I won't hear anything, just myself. Yeah. Yeah. Okay.
Okay.
Shall I mute the original audio?
Yes. We're going to start, and after that, I tell you, and you start with your talk. Let me initiate the meeting.
Great.
Muy bien,
Yeah.
estimados amigos, vamos a dar inicio a este tercer Improving Standards in HIV Care, que por primera vez es en su versión virtual. Los 2 años anteriores, 2018 y 2019, tuvimos el gusto de juntarnos, de compartir muy gratos momentos. Esta vez, como ustedes saben, la pandemia nos ha obligado a confinarnos y mantener el vínculo a través de Internet. Hemos preparado un programa muy ambicioso que aborda los principales avances que se han producido en materia de VIH-Sida en el último año y los problemas que afectan a nuestra región, habiendo llegado ya al 2020 y bastante lejos de las metas 90-90-90 que se plantearon en algún momento. Todo eso lo vamos a analizar en estas 3 jornadas, jueves, viernes y sábado. Tenemos la alegría de tener alrededor de 500 personas inscritas de distintos países. Les quiero dar la bienvenida a los 136 inscritos de Colombia, los 108 inscritos de Ecuador, los 98 inscritos de Chile, los 45 inscritos de Perú, los 27 de Venezuela, los 34 de Argentina, los 13 de México, los 7 de Guatemala, de Uruguay, los 4 de Costa Rica, y en fin, Bolivia, Paraguay, Honduras, Guatemala. Esta es la red latinoamericana que nos ha entregado tanta información y nos ha permitido también generar propuestas para enfrentar de la mejor manera el tema del VIH, y se hace especialmente necesario en estos tiempos en que la pandemia COVID ha golpeado fuertemente lo que es el testeo y la prevención del VIH. Contamos con speakers muy connotados, en particular nuestro principal speaker, el doctor Anton Posniak, y tenemos el apoyo irrestricto de la industria farmacéutica, de nuestros laboratorios amigos, que nos han apoyado en esta iniciativa. Y antes de comenzar con la presentación del doctor Posniak, quiero dejarlos con el stand virtual de nuestros patrocinadores y retomamos de inmediato.
Dovato, un salto a la nueva era en el tratamiento para personas viviendo con VIH. La potente combinación de 2 drogas en dosis fija, disponible en el mundo y hoy en Chile. Dovato, con la eficacia duradera y poderosa de dolutegravir. Alta barrera a la resistencia, con 0 mutaciones de resistencia versus un esquema de 3 drogas. Sin TDF, tenofovir a la fenamida ni abacavir. Dovato, el primer régimen en un comprimido diario basado en 2 drogas.
El compromiso de Gilead por una eventual erradicación del VIH ha sido firme. Hemos seguido progresando constantemente con medicamentos efectivos que se han vuelto progresivamente más simples de tomar, más fáciles de tolerar y más seguros a largo plazo. Por lo tanto, el VIH se ha convertido en una enfermedad crónica tratable. En América Latina, cada vez más y más pacientes tienen acceso a nuestras terapias innovadoras que salvan vidas y mejoran su calidad de vida. Nuestro compromiso es permanente y aún queda un largo camino por recorrer, pero está en nuestras manos triunfar. Debemos continuar trabajando y hacer posible, y no solo lograr que nuestros pacientes sean indetectables, sino también a un estado de salud y bienestar integral.
Well, Dr. Posniak, we have a simultaneous translation in case you want to be connected every time when we speak in Spanish, you know. You may select the channel and listen to the translation. Bien, muchas gracias por estar en línea y por seguir incorporándose a este congreso virtual. En este momento es mi agrado presentarles al doctor Anton Posniak, a quien ustedes conocen muy bien, nos ha acompañado desde un principio en esta iniciativa latinoamericana. Estamos muy orgullosos que para el doctor Posniak este sea un evento de alto nivel y siempre presente en su ocupada agenda. El doctor Posniak es Fellow del Royal College of Physicians, past president de la International AIDS Society, miembro del Governing Board del European AIDS Clinical Society y presidente del European AIDS Trial Network, principal investigador del Project Test and Treat en Tanzania, miembro de la British HIV Association y una serie de otras funciones que ha desarrollado a lo largo de su carrera, verdaderamente un extenso currículum, un gran investigador en el área de VIH y también redactor de guías clínicas y recomendaciones. El doctor Posniak nos va a hablar de antirretrovirales, metabolismo, obesidad y más. A great pleasure, Dr. Posniak, to have you among us, and we hope to share beautiful moments next year in the 4th Improving Standards.
Thank you so much, Carlos. That's a wonderful introduction, and I'm really sorry that I'm not live with you there in Santiago. So I'm now going to start my talk. If we could have the first slide, thank you. So I'm going to talk about antiretrovirals, metabolism, obesity, and beyond. Next slide. There are my disclosures. Next slide.
you can pass the slides, Anton. You have the control.
Oh, I can. Oh, great. I'm trying to do that now. I'm not sure how.
Not working?
Oh, yeah, now I am. So here's my outline. I'm going to talk about some definitions of obesity and epidemiology. I'm going to talk about obesity and HIV and how a lot of what we think might be obesity could be returned to health. What about the relationship of antiretroviral drugs and weight gain? I'll discuss that. And also, I'm going to give you the key lessons from the big study on weight gain, which was advanced. Is TDF protective against weight gain? And a little bit at the end about pathogenesis and, of course, about treatment. So, the size of the problem. First of all, let's define obesity. Well, everyone who has a BMI above 25 is either overweight, obese, or extremely obese. So this number 25 is something to remember when we're talking about overweight and obesity, and obese itself is over 30. So the size of the problem. You can see here in this graph of the world that obesity has increased by threefold over 40 years. 11% of the male population of the planet are obese and 15% of the females. You can see the United States is a real hotspot. And actually your region here around Chile and Argentina has also got a lot of obesity. And you can see here are some of the percentages, the prevalence. Chile's quite high at 28.8% compared with the global, Brazil 22.3%, Argentina again 28.5%, and Peru 19%. Now, there is a thing called morbid obesity, where the BMI is over 40. That's again more than tripled since 1993. And imagine on this planet, 2% of men and 4% of women, 4 in every 100, are morbidly obese with a BMI of over 40. Now, I'm also going to show this data on overweight. In other words, a BMI of over 25. And 1.9 billion adults on the planet have got a BMI of over 25, and that is quite enormous. And you can see here from your region, there's a lot of hotspots in the red and in the orange. Now, why is that important? Well, obesity is incredibly important because of health risks: hypertension, heart diseases, strokes, diabetes, cancers, depression, fatty liver, arthritis, asthma, sleep apnea, and poor pregnancy outcomes are all related to obesity. And high blood pressure is twice as common amongst obese adults as amongst those of a normal weight. And the number of people diagnosed with diabetes has increased by 60% in the last decade. Now, here's a graph of what happens when your BMI starts to rise. So as soon as your BMI starts to go up, you can see these black dots. And if you look along the x-axis here, you can see that as the BMI goes up, the hazard ratio of death goes up. And an increase in BMI of 5 increases your risk of death by 30%. And there are 4 million deaths per year due to overweight or obesity. Most of these are related to cardiovascular disease. So having a BMI above 25 or above 30 is a serious problem. Now, you've got to ask, what about weight gain? What is normal for weight gain? Well, it's quite incredible that an average United States adult will gain 0.5 to 1 kilogram per year from early to middle adulthood. And please try and remember this, up to 1 kilo a year of weight gain from early to middle adulthood when we look at the other data. Now, I'm now going to talk about HIV and obesity. So obesity is common and becoming more common in people living with HIV. 27% of people living with HIV in low and middle income countries are overweight or obese. Here are the numbers here of overweight and obese. And you can see that being overweight or obese is related to a higher risk of diabetes and cardiovascular disease. It's the same for people who are HIV negative. As their weight goes up, they're more likely to get diabetes, and it's the same with people living with HIV. And again, for every couple of kilos of weight gained, there's an increased risk of diabetes in about 14% in people living with HIV, and it's less actually in the HIV negative. So there's an increased risk in people living with HIV if they gain weight in developing diabetes. Now, there's a lot of contributors to body weight. I'm not going to go all through this. We know about diet and habits like alcohol, activity, not doing any, and there are other host issues, and of course, mental health and depression. And I'm going to talk about what contributes to body weight gain if you're HIV positive. Now, it's not just the food you eat. There's also, it's really interesting that as you get older, it's more easy to gain weight. People of lower high school education also have more weight gain. People from low socioeconomic minority backgrounds, and this data was mainly from Hispanics in the United States, from Texas, that they had a much more increased risk of gaining weight, and females. But what about antiviral therapy? What role does antiviral therapy play for our patients in terms of gaining weight? Well, this is a really interesting slide. So weight gain is common when you start antiretroviral therapy. Now, a lot of people think that this is because if you're HIV with lots of inflammation going on, that inflammation goes down and you're able then to gain weight and return to health. Now, if you look at this graph, the horizontal lines, the people who have normal BMIs, if you look as we go along, their risk of death as they gain weight goes down. So the weight change here along the x-axis, you can see those straight lines as they put on weight, they get less likely to die. Now, the people who are overweight and obese has no impact on their risk of death if they start to gain any weight. So this was thought that people who are underweight, who are slim, who then go on antiretroviral therapy, gain weight, and actually their health improves. This return to health has also been seen in other studies. You can see here in green, people who with HIV, they start off with a lower weight, BMI, and you can see over 12 years, their BMI goes up by about 0.2 kilograms per meter squared per year. And when you compare them with the HIV negatives who started with a higher BMI, you can see here that by the end of 12 years, they have very similar BMIs. In other words, they've got a return to health. We've also seen this in other cohorts where if you look at normal or underweight people over 12 years, return to health. In people who are overweight, again, even those people over time have just a bit greater BMIs than those who are HIV negative. And if you look at the obese, it's pretty well flat. They over time, they don't gain very much weight on treatment. So if we then say to ourselves, well, maybe antiretroviral therapy, all it's doing is returning people who are underweight back to normal health. And that's why we've been seeing these strange changes in weight overall on antiretroviral therapy. But then we have to explain this. There seems to be a greater weight gain with some antiretrovirals compared with others. And when you look at this data from Paul Sachs, you can see that the greater weight gain is with TAF, either versus, when you compare it with TDF, so zolpidem or abacavir, the weight gain is greater on those regimens. And also, interestingly, with bictegravir or dolutegravir versus efavirenz. So it seems though that there are some drugs that causes more weight gain than others. And Paul Sachs has looked at this in more detail. On the left-hand panel, you can see here that the weight gain is greater with integrase inhibitors compared with PIs and non-nucleosides over 96 weeks. And that when you look at the different integrase inhibitors, bictegravir and dolutegravir seem to have a greater risk of putting on weight than elvitegravir. And when you look at the nucleosides, TAF greater than abacavir, greater than TDF, and greater than AZT. The problem with AZT, of course, it did cause lipodystrophy and lipoatrophy. Now, we got lots of data from cohorts, and if we look at ART naive patients, we can see the same thing. Integrase, more weight gain than PIs than with non-nucleosides. So although this may be a return to health, it's a bit more than that with integrases than with non-nucleosides. And this time, we didn't have the data from in this cohort on bictegravir, but dolutegravir, again, greater than elvitegravir, very similar to the Paul Sachs data in this cohort. Now, is it dose related? And there's a hint of that, here, that if you look at dolutegravir in the early studies of 10 milligrams, 25 and 50, you can see there seemed to be a greater weight gain as the dose went up. But there was another study by the ANRS, and they found no correlation by actual PK values of the dolutegravir and 3-TC min weren't associated with weight. So we don't really know whether it is dose related or not, just a hint of an idea that it might be. Now, what about the injectables? Well, the injectables also appear to put on weight. And you can see here that this integrase class effect, and this is with cabotegravir, that the weight gain with cabotegravir versus current therapy is greater. And here's cabotegravir here. But now we're comparing it with dolutegravir, but that's another integrase, and it's very similar. So again, it seems to be a class effect of all of the integrases in increasing weight. What about switching? Well, it's very interesting when you look at switching. This is our data from NEAT, and we could, when we switched patients from a PI onto dolutegravir, they had more weight gain than continuing on the PI. At the end of 48 weeks, when we switched those people onto the integrase inhibitor, they gained weight at this trajectory. And you can see the BMI changes. So we had a hint there that actually switching people who were stable onto an integrase did make their weight go up. But these are very small changes, 0.8 of a kilo. And we've seen similar data with other switch studies. First of all, interestingly, almost nothing in terms of weight gain when in the Tango study, when there was a switch to a tenofovir-free regimen. In other words, they switched to dolutegravir 3-TC, and almost no change in the weight over that period of time. If you compared it with those that continued on their TAF-based ART, again, they didn't change much either. So it was very interesting that switching had very little effect on weight. And in the OPERA cohort, you can see here, these are patients who were on their stable therapy, slightly increasing weight year by year. Remember, I told you up to half to 1 kilo people gain every year in weight. And then when they switched from TDF to TAF, they did have weight gain. And you can see here, either whether we're on an integrase or an NNRTI or a boosted PI, there was a weight gain. Now, why was this weight gain? Why did it occur? And I'm going to come to this as a theory a little later on. We saw in Glasgow patients who were switched from a boosted PI to bictegravir, emtricitabine, tenofovir, and almost no change in the weight actually in those that switched and those that remained. So it seems very different in the switching cohorts to those that are naive in terms of weight gain. Now, is this all related just to being HIV positive and going on drugs? Well, let's look at the PrEP trials. Now, in the PrEP trials, these are HIV negative persons going on various antiretroviral drugs. Now, in IPREX, you can see here that actually people on TDF tended to lose weight. And that is something to remember. Is there something special about TDF rather than TAF that makes you lose weight? Here in the Discover, here's those patients, sorry, this is on TAF. Those patients on TAF gained weight. Those patients on TDF had stable weight. What about patients given cabotegravir as PrEP? They got 1.1 kilo in this study versus 1 kilo from placebo. So there's very little difference at all. And here in the recent data from cabotegravir versus TDF-FTC, you can see a 1 kilo difference. So there seems to be, even in the HIV negatives, if they take TAF or an integrase, some weight gain. Now, I want to really try and bring out some of the lessons we've learned from the ADVANCE trial. Now, the ADVANCE trial was in ART naive patients. It was in South Africa. The patients were Black African, male and female, and they were given 3 regimens: dolutegravir plus FTC TAF, dolutegravir plus FTC TDF, and efavirenz FTC TDF. So it was efavirenz versus dolutegravir and TDF versus TAF. Now, what did we learn from that? The first was there was a difference in weight gain in the regimens. Efavirenz had the least weight gain, both in men and women. Dolutegravir had more weight gain, but when you put dolutegravir with TAF rather than TDF, there was even more weight gain, and it was more marked in women, our second point. So difference in the regimens and difference in the sexes. And interestingly, especially in the females, the weight gain was continuing to rise at 96 weeks. The next thing was the mass increase was mainly fat. You can see here from the DEXA scans rather than muscle, and it was more in women than in men. And the gain of the limb and the visceral fat was not classic lipodystrophy. It was basically evenly distributed. These people were basically becoming fatter. They weren't developing a sort of strange form of lipodystrophy at all. Then this very interesting phenomenon. They looked at patients who had who were fast metabolizers of efavirenz versus slow metabolizers, and they looked at patients as well on the dolutegravir arm. So they looked at the cytochromes which metabolize efavirenz or not. And it's very interesting that if you were sort of an intermediate, your cytochrome was of the intermediate style, your weight was pretty stable. Here's dolutegravir. Whereas if you metabolized efavirenz, and so you have an extensive deficiency, so that your efavirenz levels were very high, you could see here that if you had high efavirenz levels, again, you lost weight, and maybe that's because you didn't sleep or there were other problems. But if you metabolized efavirenz very rapidly, you put weight on very quickly. So there is something quite strange about the fact that weight gain with dolutegravir went up, but if you metabolized your efavirenz very quickly, it also went up. But if you didn't metabolize efavirenz, it suppressed your weight. So instead of thinking now that antiretrovirals might increase your weight, it may be a return to health, but some antivirals suppress your weight. So it's really turning the whole question on its head. Now, there were consequences, though, of people gaining weight. And here's some treatment emergent metabolic syndrome, more in the women than in the men. But there was no, the only statistical difference in the arms was the metabolic syndrome, not in terms of other metabolic abnormalities. But there are consequences of weight gain in the ADVANCE study. But again, I'm coming back to this question: was most of this return to health phenomenon? When you look at this data now, we're comparing the weight, the BMI in the women at the end of 144 weeks. Now, the BMI in the women, the average BMI was 30, and in the men, 24.2. If you take an average South African woman from the population data, their BMI, average BMI is 29. If you take a man, it's 24. So at week 144 in the advanced trial, the women here and the men are very similar to the South African population. So over that time, have they just returned to a normal weight? The last lesson is, does TDF prevent weight gain? So I've said that ephedrins, if you have high levels, looks like you suppress any weight gain. But does TDF also prevent weight gain? Well, if we look at the two regimens with TDF in, the weight's not as much as with TAF. And obviously, you can see that if instis cause more weight gain than ephedrins, because ephedrins is actually suppressing your weight, you can see the difference there. But also, when you move away from TDF to TAF, you can see that you gain more weight. So is this plus 10 kilos in women a return to normal, that the 5 kilos is suppressed because of the TDF, and the 3 kilos because both ephedrins and TDF is suppressing your weight? It's very interesting to think of it in a different way. So, and there's more data here. If you look at the Gemini study with dolutegravir 3TC here versus dolutegravir FTC and TDF, in the TDF arm here, you can see the weight gain was less. On the left-hand side here, of course, all we've got are non-TDF regimens. And I've already spoken here about the advanced study. So maybe TDF prevents weight gain. Now, the other problem we have is this, is that with the same regimens, people are reporting weight gain in different ways. Here on the left, they're reporting median weight gain. On the right, we're looking at mean weight gain. And these are often looking very different, so we mustn't mix them up. And why is that important? Well, I think the clue comes from this study here. If you look in the, oh, sorry, let me just go back. The doravirine study looking at weight gain. Now, here we are. If you look at the mean weight gain, you can see the standard error bars are pretty close to the actual mean. When you look at the median weight gain, we suddenly notice that these error bars are very big. The intervals are really big. So you wonder whether or not a lot of the weight gain might be driven by some outliers up here. So it may be outliers that are driving some of the changes that we see when we talk about weight gain. What about pathogenesis? Have we got any idea why an integrase might cause more weight gain than a non-nucleoside? Well, I've just put this on because it's very complicated. First of all, we have our brain, and we have to understand all the mechanisms that might be going on to control weight gain with 86 billion neurons and over 100 neurotransmitters. And there's lots of neurochemicals that stimulate or inhibit our appetite. There's lots of things which modulate that, from lifestyle, circadian rhythms. We have our peripheral organs, which also control various episodic signals you can see here, including adiponectin, leptin, ghrelin, cortisol, etc. So it's incredibly complicated to try and work out what might be causing weight gain. We've done some study in NEAT, which is a switch from a PI to integrase. Your lipids improved, and the adiponectin went down, and the adiponectin going down correlated with the BMI. So it was very interesting that low adiponectin made your BMI go up and vice versa. And adiponectin levels are associated with a protect against obesity. So adiponectin might be a way in which integrases work. And then there's this other data that's recently come out basically showing that gene expression and fibrosis in fat, as well as inflammation in fat in macaques and in humans, can be affected by integrase. However, the doses of integrase given are quite high to get these changes to appear. So is it adiponectin? Is it to do with adipocytes? We don't know. There are other mechanisms binding to these MC4 receptors, making you hungry, increased calorie intake, leading to increased calorie intake and reduced metabolic rate. And it may be that when you go on antiretroviral therapy, you reduce your physical activity. And in fact, Dr. Garaldi has suggested that's the case. Now, if you are obese, what's the treatment? Well, first of all, it's lifestyle modification, diet and physical activity. And all of you who know, been locked in from COVID, know how difficult it is to modify your activities and your diet. Pharmacotherapy is unproven. There can be some endoscopic therapies on the stomach to try and stop outflow. And of course, bariatric surgery. So we have to get diet. We have to make a really good diet, especially if you're diabetic. Lots of exercise. There are some surgical interventions that work, and medical interventions are under investigation. But really, the hallmark is to do diet and exercise. What about switching drugs? Well, we have very little data about this. We've seen data where you switch onto integrases, but switching off integrases and see if you lose weight so far is very anecdotal. But we do need some studies to look at that very carefully. So in conclusion, we do have an epidemic, a pandemic of obesity. But the weight gain in people living with HIV, is this a return to health? How much does gender, we've seen it more in females, play a role? Genetics, we've seen it more in Black Africans. And what about a few people may have some predisposition to weight gain, which then skews the data for everyone else? What about the role of specific drugs? It looks like integrases and TAF make you put on weight, but maybe that's because the other drugs, and we've seen that concentration of ephedrins and the TDF suppress your appetite, and therefore you don't gain weight so much with other regimens. The pathogenesis so far is unknown, and so far our best proven treatment is diet and exercise, and the role of switching off an integrase and TAF so far is unknown. So I hope that's given you some food for thought. I'd like to thank you very much. Muchas gracias.
Thank you, Anton, for your terrific presentation and the very beautiful slide you showed. About this very hot topic, I'm sure that many questions will arise. By the moment, I have a question for you. In your experience, have you needed to switch any patients for weight increase in integrase inhibitors, and what the impact was of the switching?
Yeah, so in general, I've been working with the South African group trying to put together some sort of guidelines for switching if they put weight on. And we've done this in the clinic in some patients who have gained a large amount of weight rapidly. Now, maybe they are what I call one of the outliers, that if they go on a treatment, they will gain weight very, very fast. Yeah. And so far, we've not seen very much improvement in terms of losing weight. Their weight stays stable, but we haven't seen very much in terms of losing weight unless they go on a really good diet and exercise more, which of course during this COVID period has been very difficult for people. So I don't have any trial data, just anecdotal data to suggest that we haven't seen a marked improvement once they've gained the weight.
Les recuerdo a los asistentes que puedan hacer las preguntas por chat, o también pueden levantar la mano, tienen habilitada la opción de levantar la mano y hacer la pregunta directamente al doctor. Doctor, sorry, Anton, I remember you can listen to the questions in Spanish and you have simultaneous translation in the banner in the bottom to the right. Interpretation or language, you can select English and the questions will be translated.
Yeah, thanks. Yeah, I have that. Thank you.
¿Alguien quiere hacer una pregunta?
In Chile, you have a lot of obese patients, yeah? It's 28%. It's very high rate. Are you concerned about starting patients on integrase or TAF in those patients who present with obesity?
Yes, the numbers are even worse. In Chile, 74% of population are overweighted or obese. Only 25% are in a normal weight, you know. So that is a real problem to start therapy. And in my personal practice, I talk to the patient before antiretroviral therapy initiation in terms of the possibility to have a weight increase. And in some cases, patients say me, no, in case I gain weight, I prefer not to take medication. It's a problem, you know, because you know that some people have an important weight increase with therapy.
Yeah, I saw there was a question about the experience with doravirine. So yes, now the issue with doravirine is we don't see as much weight gain with doravirine, but it's mainly given as a combination tablet with TDF inside, with TDF and 3TC. So by giving doravirine, we're also giving TDF. And if TDF is suppressing weight gain, then we don't see as much. And it is true, we don't see as much weight gain with TDF and doravirine as we do with, say, dolutegravir or bictegravir and TAF. So it's interesting. To get the pure effect of doravirine, we'd have to give it with maybe 3TC alone, but that would be dangerous, or with, say, 3TC abacavir. And then we would be able to, or with TAF itself, but TAF may also cause a problem. So yeah, it would be very interesting to know if we could see what the pure effect of doravirine is.
We have to wait for doravirine and islatravir, I think a couple of years, you know, so that will be the moment to know about the real impact of this non-nucleotide in terms of weight gain. It's interesting that Dr. Jenny Hernandez from Venezuela say exactly the same you just said. More than any question, I would like to comment that the challenge in the Venezuelan reality are even greater. Treatment for HIV is reduced to dolutegravir, tenofovir, lavivudine, making it possible to change the skin regarding the risk of obesity, you know. And I believe it's the same in many countries. Many countries are evolving to a one-size-fits-all, you know. For instance, Brazil is dolutegravir, Mexico is bictegravir, so that you don't have the chance to really tailor the therapy to the patient needs.
Yeah, no, it is a public health approach, and the alternatives that they've given to the dolutegravir, TDF, and either 3TC or FTC has been efavirenz 400 milligrams with TDF and 3TC or FTC. So, and most of us are very cautious about moving back to any efavirenz regimen after it's been a wonderful drug for many years, but then the big problems with the side effects and especially the depression and suicide have made most of us very anxious about using it again.
Yeah. There are two more questions, similar questions. Dr. Posniak, do you have experience with bictegravir and weight gain, and experience with Simtusa and weight gain?
Yeah, so we have it. I mean, the trials show around 3 kilos of weight gain after 48 weeks with bictegravir, very similar to dolutegravir. And we've had experience of giving bictegravir. It's a very commonly used combination, of course, bictegravir with TAF, FTC. And yes, we have had patients with weight gain. But again, it's very interesting that we document this. And not everybody, of course, gains weight. It's so there are some people with predisposing either genetics or some other factors which makes them gain weight. But I want to just tell you all now that I think it's the same in the general population. If you talk to members of your family, they will go, I put weight on very easily, yeah? And others say, well, I'm eating all day and I don't put weight on. So I don't know whether HIV patients are very different. If one takes bictegravir and the other takes bictegravir, one may put on a lot of weight and one may not because of other issues apart from the drugs. But we don't know. That's why I think this is a really interesting subject for us to do a lot of very good research before we say that all these drugs make you gain a lot of weight. It may be that other drugs are suppressing your weight, number one. And number two, you may be somebody who have other predispositions that when your HIV is under control and you're healthy, that you'll rapidly gain a lot of kilos.
Yes, the problem is that you don't know that before starting.
No, we don't have a marker. We don't have an HLA or some other test for this at all. No.
Okay. From Elena, another question. We don't have TAF at the public level. Sometimes, fortunately, looking at obesity, but if you were to change antiretroviral because of obesity, when and what drugs too?
Yeah, so when we switch, we have been very lucky that we've been able to have doravirine, which has in the trial shown some weight gain, but not as much as with the integrase. And we give them TDF if we can, if they're on a TAF regimen. Now, the problem with TDF, of course, is bone mineral density and renal problems. And then there is an issue with what to do. We've used Dovato as well, because then instead of having 2 drugs, dolutegravir and TAF, which might make your weight go up, we've just got the dolutegravir. So we've switched to Dovato as well. But if we can, we give a non-nucleoside plus TDF. But obviously, you have to worry about their bones and kidneys.
Sure. And what about rilpivirine?
Yes, well, rilpivirine has had some weight gain, and we're going to find out more about rilpivirine, a lot about rilpivirine, because of injectable cabotegravir rilpivirine is going to be rolled out across the world in the next year, I would think. So I think we're going to see very interesting data of cabotegravir rilpivirine and compared with those people who just get cabotegravir. Because they're all the PrEP patients. Okay, so it's going to be really interesting to see if there's a differential between cabotegravir given to patients who are at risk of HIV and HIV patients given cabotegravir and rilpivirine. So yes, rilpivirine does cause some weight gain, but it's not as significant as we've seen with integrase inhibitors.
Here we have a very long question. I will try to make it short. What is your practice in elderly patients that have metabolic problems, hypertension, dyslipidemia, fatty liver, diabetes, etc., in terms of starting with integrase inhibitors or switching integrase inhibitors in this particular setting?
Yeah, so I mean, the biggest, first of all, one of the issues for these patients are drug interactions. So one of the things that we have to be very careful of is they're on a lot of they have a lot of comorbidities and they have a lot of other drugs. And of course, integrase inhibitors are very good drugs for few drug interactions. So is rilpivirine, but the problem with rilpivirine is you have to eat with rilpivirine, so that sort of is an issue. And doravirine, again, is another drug which those patients can take, which have few drug interactions. So in terms of that, and then the big issue for us would be their renal problem and their bone problem about trying to avoid TDF. And so if they've got no resistant mutations, we've often given those patients either doravirine plus TAF FTC, so they've only got one drug that might be an issue with weight gain, or we've given them dolutegravir 3TC, and then again, you don't give two drugs, because when you look at the advanced data, having both TAF and dolutegravir seem to be the big issue. But it is difficult, because what we're now all doing in practice is going, where are the drugs that we like to give that don't have side effects like ephedrine does, or you don't have to take with food like rilpivirine? Where are there are not an integrase that's not TAF or TDF. What drugs have we got left? So some people are now going back to use abacavir, but in somebody elderly with comorbidities, you don't want to give them abacavir because of cardiovascular risk. So we're becoming very narrow in our choices in these sorts of patients. And so I can't really say, apart from you have to do it person by person at the moment.
Definitely one size does not fit all.
No.
Okay, thank you, Dr. Posniak. You are more than invited to be with us for along the whole conference, and we wait for your next talk at the closure ceremony.
Thank you very much indeed. It's been a delight to speak to you all. Thank you so much, and thanks for such interesting questions.
Okay, thank you, Anton.
Thank you.
Nos cambiamos al español ahora. Estamos 5 minutos tarde. Es el momento del receso. Vamos a parar durante 10 minutos para después seguir con el simposio Metas 90-90, donde estamos. Los dejamos nuevamente con nuestro stand virtual y los esperamos en 10 minutos más a las 20:05.
Hi, it's Anton here. Can you hear me? Oh, hi, yeah. It's 11 o'clock at night now where I am. So,
hemos seguido progresando constantemente con medicamentos efectivos que se han vuelto progresivamente más simples de tomar, más fáciles de tolerar y más seguros a largo plazo.
Yeah.
Por lo tanto, el VIH se ha convertido en una enfermedad crónica tratable. En América Latina, cada vez más y más pacientes tienen acceso a nuestras terapias innovadoras que salvan vidas y mejoran su calidad de vida.
Hello, can you hear me now? Yeah.
Es permanente y aún queda un largo camino por recorrer, pero está en nuestras manos triunfar. Debemos continuar trabajando y hacer posible, y no solo lograr que nuestros pacientes sean detectables, sino también a un estado de salud y bienestar integral.
Here we go. Now, so it's 11 o'clock at night here.
Dovato, un salto a la nueva era en el tratamiento para personas viviendo con VIH. La potente combinación de dos drogas en dosis fija, disponible en el mundo y hoy en Chile. Dovato, con la eficacia duradera y poderosa de dolutegravir. Alta barrera a la resistencia, con 0 mutaciones de resistencia versus un esquema de 3 drogas. Sin TDF, tenofovir a la fenamida ni abacavir. Dovato, el primer régimen en un comprimido diario basado en 2 drogas.
Muy bien, comenzamos con nuestro stand virtual y le damos paso al doctor Martín Lazo, CEO de la Corporación SIDA Chile, para moderar el siguiente simposio.
Muy bien, muy buenas tardes o muy buenas noches a todos, queridos amigos de Latinoamérica. Es realmente un gusto, un placer personal poder dirigir esta interesantísima sección de este curso. Soy Martín Lazo, infectólogo, y soy miembro del directorio de la Corporación Grupo SIDA Chile y miembro del taller latinoamericano. Esta sección se va a componer se llama, digamos, el 90-90-90. Llegó el momento del final de estas metas que nos planteamos y queremos saber en qué situación nos encontramos en Latinoamérica y en qué situación se encuentra en parte del mundo. Contamos para esta sección con 4 distinguidísimos y excelentes exponentes. Está la doctora Ana Paulina Celi, del Ecuador. Está la doctora María Marta Greco, de la Argentina. La doctora Andrea González Rodríguez, de México. Y vamos a partir con Carlos Beltrán, que es ampliamente conocido por todos nosotros. Carlos es profesor titular de la Universidad de Santiago de Chile, jefe del Departamento de Medicina y del Programa de Posgrado de Infectología Adultos de la Universidad de Santiago, jefe también del Departamento de Infectología del Hospital Barros Luco, presidente de la Corporación Grupo SIDA Chile y de coordinador del taller latinoamericano, además presidente del Comité de VIH-Sida de la Asociación Panamericana de Infectología. Carlos nos va a hablar de las metas 90-90-90 y la pregunta fue: ¿Latinoamérica dejada de lado? Adelante, por favor, Carlos.
Muchas gracias, Martín. Bueno, es muy relevante abordar este tema y la verdad es que si estuviéramos muy atrasados de tiempo, la respuesta sería sí, fue dejada atrás América Latina, pero como estamos más o menos dentro del tiempo, vamos a decir por qué. Estas son las cifras que ustedes conocen, que corresponden al año 2019, con 38 millones de personas viviendo con VIH en el mundo. Claro que siempre pongan ojo, como me enseñó Pedro Circo, que el intervalo de confianza va de 31 a casi 45 millones de personas, y 1,7 millones de nuevos infectados en 2019, con un rango que va de 1,2 a 2,2 millones de infectados, lo que nos habla claramente que estas son estimaciones. Ahora, les recuerdo que la meta para el 2020 es 500.000 nuevas infecciones y en 2019 hubo 1,7 millones de nuevas infecciones. Por lo tanto, si nosotros pensamos que en 2011, cuando se trazaron estas metas, estábamos acá y la idea era llegar aquí, vean cómo la curva, si bien es cierto, ha disminuido efectivamente en los últimos 9 años en un 23% a nivel mundial, claramente no va a llegar el 2020 a 500.000 nuevas infecciones. Pero este 23% de nuevas infecciones a nivel mundial en el año 2019 es una mezcla de sumas y restas en el mundo. Estas son las nuevas infecciones y claro, si ustedes ven, dicen, no, sigue siendo el sur de África, el África del sur y oriental, la que tiene el mayor número de nuevas infecciones. Pero si uno hace un comparativo de lo que ha ocurrido en el tiempo, fíjense que es precisamente la región del mundo donde más han disminuido las nuevas infecciones, en un 38% en los últimos 9 años, en África del sur y oriental. África central y occidental también ha disminuido sus nuevas infecciones en un 25% y son las principales responsables de esta baja a nivel mundial en un 23%, junto, por cierto, con Europa central, occidental y Norteamérica, que han tenido una baja no tan importante, pero clara en los últimos años del 15%, a diferencia de otras regiones como África del Norte y Oriente Medio, que han tenido un aumento de un 22% en las nuevas infecciones en los últimos 9 años, y la que gana por lejos es Europa Central y Oriental, que ha tenido en los últimos 9 años un aumento de un 72% en las nuevas infecciones. Y si ustedes se fijan, mayoritariamente en hombres, que es lo que está en marrón en esta diapositiva. Pero se trata de hablar de Sudamérica. En este escenario mundial, ¿cuál es la tendencia en Sudamérica? Sudamérica, Centroamérica y el Caribe, ¿cuál es cómo se comporta frente a esta baja de un 23% a nivel mundial? Y ustedes ven, por ejemplo, que el Caribe va muy bien, va muy parecido a la tendencia mundial, con una baja, según UNOCIDA, de un 29% en las nuevas infecciones, tanto en mujeres como en hombres, pero Latinoamérica tiene un aumento de un 21% en las nuevas infecciones en estos últimos 9 años. O sea, aquí claramente nos separamos de esta tendencia del Caribe y nos ponemos a la par con Europa Oriental y Central, y con Oriente Medio y Norte de África, en términos que son las regiones que van en sentido contrario. No es que no estén disminuyendo lo suficiente las nuevas infecciones, sino que por el contrario están aumentando. Y en América Latina se da esta particularidad, que este aumento es exclusivamente en hombres. Un 31% de aumento en hombres versus un 0% de aumento en mujeres. Insisto, a nivel mundial una baja de un 23%, en Latinoamérica un aumento de un 21% en las nuevas infecciones. Y estas estimaciones siempre han sido inferiores o más conservadoras que las estimaciones de otra agencia, que es el Global Burden of Diseases, que en el año 2017, esto se publicó en 2019 y no hay publicaciones posteriores, pero para el año 2017, cuando ONUCIDA estimaba en 100.000 las nuevas infecciones, el GBD las estimaba en 160.000, un 60% más. Ahora, este aumento en la tendencia en las nuevas infecciones en Latinoamérica es una mezcla, tal como vimos que en el mundo este resultado final era la combinación de regiones en que aumentaba y otras que disminuía. Lo mismo pasa en Latinoamérica. Vean, por ejemplo, que en Centroamérica y Dominicana, para ONUCIDA hay una baja importante entre el 2010 y el 2019 en la estimación de nuevas infecciones, que va desde un menos 15 hasta un menos 48% según sus estimaciones. En cambio, en México no está en la estimación de ONUCIDA, pero el GBD sí le da un aumento, y aquí estamos hablando de un número mucho mayor de nuevas infecciones, 19.800. Honduras y Costa Rica también para ONUCIDA tienen un aumento en las nuevas infecciones. ¿Y qué pasa en Sudamérica? Bueno, acá tenemos que se produce la discrepancia. En verde, las estimaciones que consideran que no han aumentado o han disminuido las nuevas infecciones, y para ONUCIDA en Colombia se han mantenido estables entre el 2010 y el 2019, en Ecuador han disminuido un 11%, en Perú un 15%, en Bolivia un 15%, en Venezuela un 30% y en Paraguay un 8%. Sin embargo, el GBD para el 2017 mostraba una tendencia de los 7 años de un aumento de un 5% en Colombia, de un aumento en Ecuador, de un aumento en Perú, y con números estimados muy distintos a los de ONUCIDA, de 3.300 a 6.700, en Bolivia también, 2.500 contra 1.000 nuevas infecciones, y en Venezuela, 8.000 contra 5.000. Y en otros países, la cosa es más dramática. Brasil, por ejemplo, ONUCIDA estima que aumentó en un 17,1%, de 41.000 a 48.000 las nuevas infecciones, que es el que lleva el peso más fuerte en Latinoamérica, sin duda. Pero para el 2017 el GBD estimaba en 83.000, o sea, casi el doble de nuevas infecciones que lo que estimaba ONUCIDA. En Chile, ONUCIDA estima un aumento de un 55%, entre paréntesis, para ONUCIDA es el país de Latinoamérica que ha tenido más aumento en nuevas infecciones, según sus estimaciones, y en cambio GBD nos daba hasta el 2017 un aumento menor. Uruguay no está en las estimaciones de ONUCIDA, GBD estima que ha aumentado, y en Argentina se produce otra discrepancia. La estimación de ONUCIDA es de 5.700 a 5.900 las nuevas infecciones, y GBD estima en el doble, en 12.000 las nuevas infecciones, una situación parecida a la de Brasil. Por lo tanto, estamos hablando de estimaciones, y lo que sí sabemos es que las tendencias no son iguales en todos los países. Pero yendo a lo que ha pasado en el último año, comparando los datos 2020 con 2019, vale decir el año 2019, que es el que tienen acá, con el 2018, ustedes ven que UNOCIDA a nivel mundial considera similar el número de personas viviendo con VIH, de nuevas infecciones, 1,7, 1,7, y una leve disminución de las muertes. En el Caribe, lo mismo, similar, una baja de las nuevas infecciones y las muertes no bajan tanto. Y en Latinoamérica la cosa muy mal, de una estimación de 1,9 se sube a 2,1 millones de personas que se estima viviendo con VIH, y el número de nuevas infecciones, UNOCIDA estima que subió de 100.000 a 120.000, y que el número de muertes aumentó por VIH, aumentó del 2018 al 2019. Pero en la vida real, las cosas parecen ser aún peores. Estos son datos del taller que ustedes han visto antes. Tomamos 42 centros de 15 países que están a cargo de un gran número de pacientes bajo control, y se observó que entre el 2013 y el 2017 hubo un 64,3% de aumento en los nuevos ingresos. Ustedes me dirán, es que se está diagnosticando más, ya vamos a discutir eso. No creo que sea principalmente por el diagnóstico, sino que probablemente esto ya está reflejando que en Latinoamérica ha ido en los últimos años aumentando la transmisión del VIH. Y esta es la realidad en Chile. No tengo los datos 2019 de otros países para haber construido este mismo gráfico, pero les recuerdo que UNOCIDA decía que pasamos desde el 2010 al 2019 de 3.300 a 5.100 las nuevas infecciones, vale decir un 54,5% de aumento, siendo que los nuevos diagnósticos oficiales en Chile aumentaron en estos años el doble, en un 117%. Si vamos a mortalidad, en mortalidad lo que ha logrado, según la estimación de UNOCIDA, el mundo es aún mayor que lo que ha logrado en nuevas infecciones. Aquí se estima que ha bajado en un 39% el número de muertes, y claramente sí hay una tendencia a lograr las metas. Fíjense que en el Caribe, de nuevo, muy parecido a lo que es la estimación a nivel mundial, un 37% de disminución, pero en Latinoamérica solo un 8% de disminución de la mortalidad. Y la estimación 2018-2019, vean ustedes que en Latinoamérica hay un aumento de la mortalidad, como les mostré recién. Yendo a las metas 90-90-90, esto es lo que nos dice UNOCIDA para Latinoamérica. Les quiero poner acento en los números totales, no en cada 90 individual. Fíjense que UNOCIDA dice que en 2019 el 77% de las personas que tienen VIH estaba diagnosticado en Latinoamérica, que el 60% de las personas que tienen VIH estaba en terapia en Latinoamérica, y que en definitiva el 53% del total de personas con VIH tenía carga viral suprimida. Los números para el Caribe, las estimaciones son bastante parecidas, el mismo 77, el 63 fue un poquito más, y se cae en el tercer 90 el Caribe porque le asigna un grado de supresión virológica inferior al que le asigna la Latinoamérica. Pero estos son nuestros números. Este es un trabajo muy, muy importante del taller latinoamericano que se presentó en el EAC del año pasado, lo presentó la doctora María Marta Greco, y en este estudio nosotros vimos que de 7.750 pacientes, el 2,9% de los pacientes que iniciaban terapia moría dentro del primer año. Eso no se cuenta, se censura para el 90-90-90. Solo el 81% era retenido en terapia, y el 74,5% final lograba carga bajo 1000 POP. Pero el grave problema se da, y la conclusión a la que llegábamos, es que una vez retenidos en terapia se lograba una buena supresión virológica, pero que el grave problema para llegar a este 45,6% final estaba en el porcentaje de pacientes viviendo con VIH que estaban vinculados, que estaban bajo control en el sistema de salud, y que llegaba solamente al 60% vinculados. UNOCIDA dice que el 60% está en terapia. Por lo tanto, el enfoque debe ser claramente en Latinoamérica, en el testeo y en la vinculación, como se va a insistir en este. Y aquí está la comparación para el mismo año. UNOCIDA decía que el 61% estaba en terapia, nosotros teníamos el 61% vinculado, pero solo el 48% retenido en terapia, y de esos suprimidos nos daba un 45% final contra el 52% que daba UNOCIDA. O sea, menos que la estimación de Lucía, y en algunos países esta diferencia era notoria. Por ejemplo, en Guatemala, Lucía estimaba un 52% y nosotros teníamos un 30% de supresión final, y en Chile estimaba un promisorio 62% y nos daba solamente un 45% final. Bueno, los resultados que les mostré de ONUCIDA han llevado, creo que me quedan 5 minutos, así que voy a ir más rápido, a que se reformulen las metas ya no 2030, sino que 2025, y se agregan estos menos 10, 90 y 95. El 90 es que las personas que viven con VIH o que estén en riesgo de VIH estén vinculados a sistemas integrados de atención y que haya un menos del 10% de legislación punitiva, menos de un 10% de estigma y discriminación y menos de un 10% de inequidad. Pero poner en el centro a las personas viviendo con VIH y a las personas en riesgo para que tengan, voy a ir a las mujeres, ya sé que vienen después de mí María Marta, Ana Paulina, Isabel, 95% de cobertura de transmisión vertical, 95% de acceso de la mujer a servicios de medicina sexual y reproductiva, 95% de prevención combinada y 95% del primer 90, 95% del segundo y 95% del tercero. O sea, adelantar las metas para el 2025, cosa que se ve bastante difícil porque en la parte biomédica de la prevención integral, el testeo claramente es una deuda en muchos de nuestros países. El test and treat también tiene problemas y el testeo, evaluación de riesgo y la PrEP es una deuda en Latinoamérica. Ustedes saben que del poco más de 500.000 de personas que están en PrEP en el mundo, más de la mitad está en Norteamérica y en algunos países de Latinoamérica está implementada. Brasil lleva un poco la iniciativa, pero en Chile, que tomó esta iniciativa hace 2 años para tener a este año 2020 a 10.000 personas en terapia, fíjense que lo que se ha logrado es tener 250 personas en PrEP en vez de 10.000. Bueno, pero este es el tema. No solo que está aumentando, sino que está hiperconcentrándose en jóvenes. Estos datos ustedes los conocen. Solo les quiero destacar que al año 2018 se estimaba que el 40% de las nuevas infecciones en Latinoamérica se daba en hombres que tienen sexo con hombres. Esa estimación aumentó a un 44%. Y en cuanto al Caribe, claramente menor y muy parecido a la realidad mundial. Y esto que ustedes conocen, que es que en todos o la mayoría de nuestros países la epidemia se está concentrando en hombres de 15 a 29 años, Bolivia, Perú, Chile. Claramente 1 de cada 2 nuevos casos en hombres se da en un hombre joven. ¿Y qué va a pasar con el COVID? Les recuerdo que para las metas 2020 vamos a tener el impacto del COVID que todavía no se ha medido. Bueno, el impacto del COVID es probablemente la tormenta perfecta. Va a significar sin duda un aumento de la carga viral comunitaria. Hay más personas con VIH que están abandonando los controles y la terapia, por lo tanto rebotes virológicos. Hay menor testeo y más gente que no conoce su diagnóstico y más infecciones agudas no diagnosticadas. Por otro lado, hay menos prevención, menor acceso a testeo, consejería, menor percepción de riesgo, menor disminución de los inicios de PrEP, interrupciones de PrEP, menor acceso a la profilaxis post-exposición, y sabemos poco del riesgo de condón, y hay evidencia de que las conductas de riesgo, por lo menos en un porcentaje de la población, se mantienen. Por lo tanto, se aumenta la carga viral, se mantienen las conductas de riesgo y disminuye la prevención, no hay que ser muy brillante para adivinar lo que va a pasar. Fíjense que en Estados Unidos, con esto de la telemedicina, que pasó a ser la prácticamente totalidad de los controles, el testeo de VIH y de enfermedad de transmisión sexual disminuyó en un 85%. Una tremenda interrupción de todo lo que son las políticas de testeo y que también ha ocurrido en Latinoamérica. Fíjense que en mi hospital, si comparamos de enero a agosto del 2020 con enero a agosto del 2019, los ingresos disminuyeron en forma muy significativa y los abandonos aumentaron en casi un 25%. Entonces, menos gente testeada, diagnosticada y suprimida, y más gente que abandona terapia y rebota la carga viral. Por lo tanto, mayor carga viral comunitaria. Por lo tanto, una de las cosas que seguramente va a ocurrir es que este 36,6% de presentación a cuidados con enfermedad avanzada que teníamos hasta el 2017, va a ocurrir esto que estamos viendo. Esto es de mi hospital de ahora, de este mes, pacientes que nos llegan con toxoplasmosis. Estamos viendo mucha tuberculosis en personas con VIH y probablemente, como les digo, también nuestra mortalidad por VIH va a aumentar. Ahora, ¿qué ha pasado con las conductas de riesgo? Fíjense que hay mucha interrupción de PrEP en este reporte de Estados Unidos, la mayoría porque perciben que hay menos riesgo de adquirir VIH. Y sin embargo, muchos de los que contestaron esta encuesta reportaban un aumento de sus conductas sexuales de riesgo comparado al periodo pre-confinamiento, que son las Shelter-in-Place Orders que llaman ellos. Y si hablamos de PrEP, los inicios de PrEP en este centro de Boston que se presentaron en el AIDS virtual de este año disminuyeron en un 72% y las interrupciones de PrEP aumentaron en un 191% y especialmente en hombres jóvenes, que es nuestro problema en Latinoamérica, en los grupos raciales minoritarios o en las personas que tienen seguro público. O sea, no solo hay menor acceso a la prevención integral, sino que esto afecta particularmente a grupos más vulnerables y que por lo tanto van a estar en riesgo aumentado de adquirir VIH. Bueno, estamos dentro de los tiempos, lo único que los quiero dejar invitados para que el próximo año, estos eran los datos 2018 que se presentaron en 2019, estos los datos 2019 que se presentaron en el 2020 y un gran interrogativo de qué nos van a decir los datos de ONU-SIDA para el 2021, que ya sin COVID claramente no iban hacia la meta de 500.000 nuevas infecciones por año y probablemente con el impacto del COVID o en la parte que se alcanza a medir en este primer año de COVID, ya se va a ver que esta tendencia claramente no va a alcanzar la meta y probablemente incluso se va a revertir a un incremento en la presentación tardía y en la transmisión del VIH. Este es un bonito recuerdo de nuestro Improving Standard del año pasado, en que también nos acompañó el doctor Posniak, y ahora, aunque sea de manera virtual, era importante retomar estos temas y mi gran esperanza de que el próximo año, por allá por diciembre, podamos volver a reunirnos y ya el COVID nos haya dejado retomar nuestra vida de comunicación, de contacto y de esta manera tan latina de relacionar. Muchas gracias.
Muchas gracias, Carlos, por la excelente presentación. Vamos a dejar todo lo que son preguntas para una pequeña sesión al final de las charlas. Les quiero recordar a los expositores que deben acotarse a los 20 minutos que dura cada charla. Me dieron potestad para avisarles 2 minutos antes de que se excedan el tiempo. Y vamos a seguir ahora con la siguiente presentación. Es un agrado para mí presentar a la doctora María Marta Greco, que es médico especialista, consultora de infectología, jefe de clínica de la Cátedra de Infectología de la Facultad de Ciencias Médicas de la Universidad Nacional de La Plata, Argentina, miembro fundador y miembro del directorio del Taller Latinoamericano de VIH y de la Sociedad Viral Infectious Latin American, VILA. Miembro de la Comisión SIDA y ETS de la Sociedad Argentina de Infectología, SADI. La doctora María Marta nos va a presentar el tema, el impacto de la pandemia del COVID-19 en el manejo de pacientes VIH en Latinoamérica y en el mundo. Por favor, adelante, doctora Greco.
Muy bien, muchas gracias Martín por la presentación y muchas gracias a todos ustedes por estar esta tarde hoy compartiendo con nosotros esta actividad. Esta es nuestra agenda para los próximos 20 minutos. Muy brevemente vamos a repasar la situación VIH en el mundo y en la región, ya que el doctor Beltrán muy bien se refirió a eso en la presentación anterior. Luego, brevemente, vamos a ver la situación de COVID en el mundo y en la región. A continuación, el impacto de la sindemia o de la sinergia de estas dos pandemias y cuáles pueden ser las estrategias de mitigación para evitar el impacto de esta pandemia COVID-19 sobre la respuesta al VIH. Con respecto al VIH, como dijo el doctor, se estima que viven en el mundo aproximadamente 38 millones de personas, de las cuales la mayoría son adultos y más de la mitad son mujeres. Se produjeron en el año 2019 más de 600.000 muertes, esto significa una reducción cercana al 40% respecto al 2010, pero una cifra todavía muy elevada con respecto a los objetivos 2020, y se produjeron, como comentó el doctor Beltrán, 1.7 millones de nuevas infecciones en el mundo. También esto significa una reducción cercana al 23% respecto al 2010, pero como pueden ver, más de 3 veces los objetivos 2020, una cifra absolutamente inaceptable. La gran mayoría de las nuevas infecciones se ha producido en el mundo en las poblaciones más vulnerables, poblaciones clave y sus parejas sexuales, y se estima que al mes de junio del 2020, 26 millones de personas se encuentran en tratamiento antirretroviral. Esta es la cascada para el mundo. Observen que se estima que en el mundo el 81% de las personas se encuentra conociendo su estatus serológico, de las cuales 82% estaría en tratamiento y de las cuales un 88% estaría indetectable. Sin embargo, cuando vemos las cifras reflejadas contra el total de personas que se estiman viviendo con VIH, solo un 67% estarían en tratamiento y un poco más de la mitad estarían indetectables. O sea, dicho de otra manera, 4 cada 10 personas en el mundo viviendo con VIH no están indetectables. Cuando vemos la cascada de cuidados de nuestra región, vemos que al 2019 un 77% de las personas
77% of people were aware of their HIV status. Out of these, 78% were using treatment. Out of these, 88% were virally suppressed. That is, we have a progress in the cascade of care of these patients. However, when we take a look at the percentages regarding the total people living with HIV, we see that only a little bit over half of people living with HIV in our region are undetectable. That is, half of the people would have a detectable viral load. Once again, unacceptable figures. As Dr. Beltran commented, there was not a decrease in the infections between 2000 and 2019, but there was an increase, and this increase has not been homogeneous. There are countries which have shown a response to this epidemic which deserves to be mentioned. Please observe El Salvador, Nicaragua, Colombia have decreased the number of new infections, and countries such as Costa Rica, Brazil, Bolivia, and Chile show increases in their new infections, which is a cause of a worry. As I mentioned, the new infections around the world are mainly in key populations and their partners, especially in our Latin American population. And we see that in Latin America, over 75% of new infections were seen in key populations. In the Caribbean, this figure reaches up to 60%. When we speak about late diagnosis, we see that in this graph, which shows figures from our workshop, covering over 43,000 patients from 41 centers in 11 countries, we see that the diagnosis with under 200 CD4 count has decreased from 40.5% to 31.9% between 2013 and 2017, while the number of diagnoses that reach care with under 400 CD4s has been stable. When we add these percentages, we see that half of patients from our cohort reaches diagnosis in a tardy or late manner, which is also unacceptable. So we see that the epidemic in Latin America is concentrated in key populations where new infections are increasing. This prior to the COVID pandemic. We have unacceptably high figures regarding late diagnosis in a region with multiple vulnerabilities, politic, social, and health vulnerabilities. With the addition of the COVID-19 pandemic. Regarding COVID-19, these are figures for today. As you see around the world, we have over 75 million cases, where unfortunately the countries with most cases include countries from our region. We have the privilege quote unquote, of being in the top 10 of countries with more cases around the world. And when we see deaths, until today, we have had more than 1.5 million deaths around the world. And once again, a couple of countries are within the cases with more deaths around the world. But what must preoccupy us are the second waves that are occurring around the world with a greater or lesser intensity. I show only a couple of figures or graphs for today as an example. Please take a look at the United Kingdom, Germany, Brazil, the United States, Mexico, and Spain, where we see that these second waves have more cases compared to the first wave. All of this in the context of a world in which we are just considering to begin vaccination. So we are quite uncertain of what is coming in our future. What is syndemia? Syndemia is characterized by the interaction between factors, both biological and social, that increase the susceptibility of people. In the case of COVID and HIV, what we have is two categories of diseases that interact in a synergic manner: the infection by SARS-CoV-2 and other communicable and non-communicable diseases. The addition of these diseases in a context of social and economical inequity exacerbate the adverse effects of these diseases in a separate manner. And chronic pathologies always are at risk during emergencies, which may be natural disasters or medical emergencies. Pandemics, wars, and natural disasters have put the focus of attention on emergent or pathologies and have left aside other areas of health. Patients with chronic pathologies are more susceptible to the stress generated by these great disasters or pandemics. So they are more vulnerable to these situations and also lack the care they require because health prioritizes emergency care and delays care for chronic diseases. And this is how we have suboptimal care because of deviation of sanitary resources, sanitation resources, interruption of routine care, discontinuation of chronic medications, overloaded emergency services or collapsed emergency services that cannot answer, give an answer or response to emergent pathologies or chronic pathologies, and interruptions or restrictions of transportations as occurs in this pandemic. And we have seen all of this in its maximum expression. People who cannot move between cities or cannot even move out of home, be it because of political or legal restrictions or because of fear. All of this leads to chronic pathologies have a suboptimal management, and there's an interruption of the care, contributing to the worsening of these pathologies. There have been great pandemics in the history of humanity. In the 6th century, we had Yersinia pestis. Then the 14th century, Yersinia pestis plague, and HIV from 1981 until now, with over 32 million deaths, which is the one that has persisted for a longer time. If we only take a look at the pandemics in the last century, by far, the HIV/AIDS pandemic is the one that has presented more cases and more deaths. During these pandemics, the health care, especially when the pandemic is for a short time, the care for chronic pathologies is deteriorated. Please take a look at the study showing the increase in mortality due to stroke or congestive heart failure or acute myocardial infarction in those hospitals which had overload due to H1N1. Those patients with greater demands for care due to this pandemic had the greater mortality. These graphs show the effects of the Ebola epidemic in 2014-15. Please look at the effects on mortality because of these causes in Guinea, Liberia, and Sierra Leone. And this was originated mostly because of lack of staff or fear of staff to acquire this disease, and also because decrease in coverage for treatment of around 50%. It is estimated that during the Ebola outbreak, this generated an additional 10,000 or more deaths. This graph I found in Twitter from a scientific publication. I had to request permission from the author to use it for this presentation. And please look at the collateral damage from the COVID-19 pandemic. It is estimated that it will generate problems in the long term. The first wave and immediate mortality and morbidity due to COVID-19 is known by all of us, but we also have the second wave due to resource restriction on urgent no-COVID conditions. We probably all remember cases of people with MI or acute appendicitis reaching the emergency unit late because of this. And then we have a third wave with impact of interrupted care on chronic conditions. This author describes also a fourth wave because of the psychic trauma, economic injury, mental illness, and burnout. Regarding COVID-19 and HIV, the impact can be defined in three main dimensions. On the one hand, as we commented, the moving of sanitation resources and limitations in mobility, but on the other hand, the stigma and discrimination was renewed and exacerbated for HIV, and deficient healthcare services before this pandemic are accentuated today during the COVID-19 pandemic. This is a survey for people living with HIV in Latin America and the Caribbean. This was an online survey using a Google form for 2,300 people living with HIV in 28 countries from Latin America and the Caribbean. 40% of those surveyed found a delay in healthcare for emergencies. 5 out of 10 people mentioned having difficulties to obtain their antiretroviral treatment, and 3 out of 10 only had medication that lasted for 2 months. 5 out of 10 only had medication for 1 month, and 2 out of 10 had medication for less than 1 month. 3 out of 10 people only received offers for healthcare through telemedicine. Under 2 out of 10 had home antiretroviral therapy. Additionally, 72% referred that their confidentiality regarding living with HIV was affected, and 31% mentioned that they refrained from using the healthcare system because of fear of discrimination. In other parts of the world, just 2 examples here, surveys performed to people living with HIV showed that 1/3 of people did not have enough medication for the treatment. 65% in China reported difficulties for access to their medication, and 3 out of 10 required psychological support. In East Europe, survey to professionals in 19 countries was performed, and 30% of clinics mentioned working normally, and 42% reported risks of not having enough antiretroviral medication. Regarding testing from UNAIDS, from the period between January and July, there has been a marked reduction in the HIV tests developed. Take a look at Guyana and other countries such as Guatemala, Honduras, or Peru. A drastic drop in the number of tests performed. What about prevention? This clinic in Boston, a PrEP clinic, registered handing out of PrEP medication, initiation of PrEP, HIV tests, and STD testing showed a 191% increase in the time to give out the PrEP medication. Initiation of PrEP was also delayed. There was a drop in the number of patients receiving PrEP in almost 20%, and there was an important decrease in HIV testing, 85%. Also, gonorrhea and chlamydia tests were decreased in a similar fashion. And this post-exposure prophylaxis clinic in London, this is an HIV STD clinic, 80% of decrease in prophylaxis prescription, PrEP prescriptions. Take a look at this line, the beginning of the confinement in the UK. There is a marked reduction after confinement, and in the few cases where PrEP was required, there was a proportional increase in prescriptions because of exposures during chemsex and slamsex. And I wanted to comment on that important piece of data. Regarding prognosis of HIV, this is cohort study from the veterans. We see that people living with HIV, which are over 30,000 people, did not show a greater rate of positivity of COVID-19 or parameters of more severity of poor prognosis, such as hospitalization, ICU admission, intubation, or death. In this study, from the US mostly, 286 people living with HIV and COVID-19 from 36 centers and average age of 51, showing a primary outcome, the need of admission to ICU or death. It was shown that age, chronic lung disease, hypertension, and CD4 count were associated to worse prognosis. This is the first study I found where a variable was specific for HIV and associated to worse prognosis. This is a small number of patients, only 286 patients, but it is a topic that requires more research. This study from the UK, using a database of over 17 million adults, including almost 30,000 people living with HIV and with a registry of almost 15,000 deaths due to COVID-19, was found that there was a greater risk of mortality due to COVID-19, and this association was more pronounced in regards to an ethnic background. There are no solid data showing that people living with HIV have a greater probability of infection, but we require more data to be able to say if this is or not a risk group for a worst evolution or death, especially in case of low CD4 counts. It must be considered that coexistence with other morbidities and age could increase the risk of a poorer course due to COVID infection, and that it is recommended that people living with HIV should follow recommendations as other people do. We should consider special situations such as economic and social factors. Regarding mitigation strategies, we should improve identification and follow-up of chronic patients with HIV, offer patient transportation or generating mobile clinics that take HIV services to the patient, to the population that requires these services, offer telemedicine services, continuity plans for handing out medication at 30, 60, and 90 days, restructuration of spaces to guarantee safe essential care, and require the collaboration of community associations that can contribute to these mitigation strategies. Telemedicine is the use of technology and telecommunications with the objective of giving remote care and is a complement to the standard of care for chronic stable patients. It improves access to specialists, reduces costs, saves time, avoids problems at work, is quite satisfactory from the side of patients, and could improve prognosis and improves the physician-patient relationship. This is a study from Boston Center. As you can see in blue, we saw a decrease in presential visits after confinement. However, there was an increase in the telemedicine visits or consultations, and this not only increased the number of people in follow-up, but it also increased compared to the same period in the previous year, with a statistically significant difference. Viral loads control decreased. However, the percentage of non-detection was kept stable. And now to end, I would like to show you this study by Dr. Cassetti from this is one of the largest cohorts in the Argentinian Republic, and you can see a survey to patients living with HIV. Due to the confinement, they presented mental health challenges such as irritability, stress, anxiety, loneliness, and depression. However, continuation and adherence to their medication was not affected, and care using telemedicine led to only 4% of discontinuation of antiretroviral therapy and 10% in non-antiretroviral therapy in these patients. As conclusions, we can say that COVID-19 is causing a decrease in access to diagnosis, prevention, and treatment of services for patients living with HIV. COVID-19 threatens the advances against the HIV epidemic and could delay its control, and the synergy between these two global pandemics will require more studies, more interventions to mitigate the effects of COVID-19 on the response of the world to HIV. We know that in the future, this will have an impact. This is what I wanted to share, and thank you for your attention. Very well. Thank you very much, Maria Marta, for this excellent presentation. You can always learn day to day, not only about medicine, but also about culture. There are many questions for you. Then we will leave for the end of the session, and we will now continue and introduce Dr. Andrea Gonzalez Rodriguez. She is not here with us today, but she has left her presentation. Dr. Gonzalez Rodriguez comes from Mexico. She's the medical director of the Condesa Specialty Clinic for HIV care from the Federal District of Mexico. She has collaborated several times in our courses, and she will speak to us about understanding prevention, challenges, and opportunities.
Good morning, everyone. I am joining you from the city of Mexico. It's a great pleasure for me to be with you in such difficult times. From the city of Mexico, perhaps the one that is hardest hit, maybe not in the world, but probably in the continent. It's a very difficult time for us in the city, but it's a great pleasure for me to be joining with you at the end of this year, because it's been a tradition to be together, and at least we can be together online. I was to speak about testing prevention during the pandemic. I will make some very brief comments based on what has happened in the city of Mexico. In the city of Mexico, as you will know, the clinics have the first level of attention. And so this gave us the possibility of maintaining our service for HIV patients during the whole pandemic with some restrictions in the closing hours. But we did maintain basically the admission of patients and treatment of patients. And we even had to admit HIV patients from other centers that were and are still devoting their full energy to the treatment of COVID-19 patients. Yes, on the 31st of October, we had 15,131 males in active treatment, 1,619 women, and 332 transgender patients. And we did some cross-checking of data between the people who were registered in our treatment database for the HIV, and we found that 193 people with HIV treatment and 98% who had received some treatment, some PrEP treatment at the Condesa clinic had tested positive. CISVER is the system that reports the COVID cases. This was cross-checked information in August with the first wave of COVID. Now we're in the second wave, in the second COVID wave. But during the first wave, we registered people in these epidemiology COVID database, 193 patients of our patients, and 18 of Condesa clinics died and were confirmed in the system. We still need to cross-check with another database of the mortality cases that is far more accurate, because as you well know, in Mexico, the testing is quite low, particularly in the whole population, and they don't include patients who have been diagnosed in private centers. But in the system, we have 198 people who tested positive to COVID. And of those people who died, we had three groups of patients. The largest group, which is half, belonged to people who had not begun the treatment or had begun recently with very low CD4. And there was another group that had comorbidities linked to HIV, like diabetes and obesity, unfortunately. And there were some other cases that we could not find any risk factors for. The largest group is the group of people who had perhaps not started the treatment or had abandoned the treatment. The ones who were hospitalized out of those 18 patients referred from the Condesa clinic to the hospitals. And herein lies the importance of testing and preventive measures in the pandemic and HIV cases. We had 2014 admissions between January and October 2019. So we had 15.1% more cases of treatment for antiretroviral treatment. And then there were patients who had dropped out of the treatment, not only at the Condesa clinic, but maybe at other places like in the National Institute of Respiratory Disease or the Social Security treatment centers that were treated at the Condesa clinic because of the pandemic. And there we had 76.1% increase. This is a very important point because in my experience, there was an increase in the risk perception among people, and that led to the fact that many people who had dropped out of the treatment in previous years reassumed the treatment, so that number was higher. If we look at the figures only in May and April, it was almost 200%. And there were people who were looking for treatment, to be readmitted to the treatment because of the COVID pandemic. That situation is very important to take into account. What we did was to reduce the follow-up visits, especially during the months where the whole city was in lockdown. And so we had less follow-up visits in those patients. And we also facilitated and made more flexible and quicker the admission of patients. Therefore, between January and October, we had 36,781 tests carried out, 3,783 diagnoses, and the prevalence of 10.2% of the people who came for testing. And we did less testing, and you will see that later in my presentation, but we had a higher prevalence. We opened, the number is wrong here, but the files of the patients were higher, the number of admissions and readmissions. In fact, 90% of the people diagnosed had an open file at the clinic. We had never come across such a situation at Condesa clinic. And that was basically because in the case of Condesa, more or less half of the records of the diagnosis that we were doing needed to be referred to a social security institution. And since we received all of them, the rest of the institutions not treat the primary level patients, only the second and third level patients. So all the hospitals that were dealing with HIV continue being COVID treatment centers now. So we received all of them, and for the first time, 90% of the people that we diagnosed opened the file at the Condesa clinic. So the number of files is much higher this year than the ones that we had opened in previous years. That's the explanation for that, and that's the increased percentage too. You have 2 more minutes. Yes, I'm about to finish. We also continue with our prison centers, and we haven't had in the prison centers, we of course controlled the wave. We had only 1 case of infection of one patient with COVID and HIV. And this is something that we did during April, May, and June. That's when the city was in lockdown. There was an agreement between INER, the National Respiratory Disease Center, and the Nutrition Center in the Condesas. And there was a private center that we did an agreement with. And what we did was to have a hospitalization area where we brought together the patients using the all the resources that we needed to use. And we had 13 patients that were hospitalized. And it was like going back to the years where we had such cases. But with this project, we were able to hospitalize serious HIV patients. And so this decreased the mortality. This space has ended, but we were hoping that it could continue. The pandemic made us come together, bring together the HIV institutions and the Condesa clinics. And so this is the end of my presentation. By way of conclusion, I think that next year it is essential for us to keep the testing and also the quick admission to the antiretroviral treatment. And we have to think about this in primary attention or care centers where we can keep the HIV treatment centers. And that we see a higher perception of risk in the HIV population, which has led to an improvement in some of our indicators. And we have managed to get people readmitted to the treatment too. And I would like to mention that the Condesa clinic lost 2 staff members, 1 assistant, and in Iztapalapa clinic, and another one also, because our staff not only work at the Condesa clinic, but also at the COVID hospitals. But we're still fighting and struggling to keep up. Thank you so much. Thank you so much, Dr. Andrea Gonzalez, for sending your presentation. It's admirable work that you're doing. I must remind you the time that you have to stick to. It's 20 minutes. And also to mention that we have an important number of people participating. We have 150 almost participants. It's a great pleasure to introduce my fellow my colleague, Ana Paulina Celi. She's also from Ecuador, as I am too, and she's has a master's degree degree from the Juan Carlos of Spain University. She's a treating physician and also the head of infectology of the Armed Force Hospital in Quito. She is a member of the technical OMS group for HIV in Washington, D.C., and also a member of the Committee for Viral Infections in Ecuador. Dr. Ana Paulina will be talking about addressing the impact of HIV, especially in the groups of adolescents and elderly people. Dr. Celi, if you may.
Thank you, Martin, for this presentation. Just to clear up, I don't pertain after 25 years to the Armed Forces Hospital in Quito, Ecuador. I'm just working in private practice. I'm professor in 3 universities, and in all of the other tasks that you have mentioned in your introduction. I would like to give a homage to all of those colleagues that are working with both pandemic of HIV and the pandemic of COVID-19 and the armed forces. We will see the impact of HIV in adolescents and elderly patients because they are the most important populations in our HIV workshop in Latin America. Our contents for this presentation are the naive adolescents, the patients or adolescents with perinatal infections, adolescents and older adults with comorbidities. And now to begin, the percentage of distribution of new HIV infections per region in children and adolescents. This projected to 2050 shows an increase in both populations in all Latin America. This means that the adolescent group will be a very important group throughout the future years. There's much to do to reach the control of this epidemic. There are less new infections in young small children, but infections in adolescents have not stopped. So the UN/AIDS goal of reduction in HIV infections in adolescents has not been reached. In this moment, we have much more than this number of infections So this means that we must have multiple new strategies, and I will cover some of them in this presentation. Another problem is that adolescents living with HIV receive an inadequate access to antiretroviral therapy. In 2017, 37% of adolescents between 15 and 90 years of age had access to antiretroviral therapy. Here is a workshop with 96,000 cases, with a proportion of those under 25 of 10%, important variations in Ecuador and Venezuela, and the general projection of people between 15 and 29 years of age was 22% in these two countries. Here we show graphs about our problem in Latin America in young women and men. This was reflected in the 2013 to 2017 workshop. Our problem is mostly young men. There's a relative stability in women. This is a world trend, not only a local trend. What we can say here is that admissions according to age, up to 39 years of age, we have 44.8%. This is a young population, the Latin American HIV population, every day more young and following the projections. What is important to say is that there is a large group that arrive late to health care. This may reach up to 31% of the group of 25 to 29. And it is not the population that arrives later. We will mention this when we speak about elderly patients or people over 50. Those are the ones who arrive later. However, the late presentation of youth and adolescents is also important. What is the influence of the Sustainable Development Objectives in mortality due to HIV? The approach of the epidemic in adolescents requires maybe a different approach in terms of poverty, improving education, obtaining adequate food and water. And this study, what is seen is if we continue to reduce the Sustainable Development Objectives, mortality increases. On the other hand, if we achieve at least 4 of the objectives of Sustainable Development in people living with HIV, specifically the adolescent group, we reduce in 38% reduce mortality from 38% to 9%. Therefore, we must think on this group of naive adolescents as a framework for the health services of the key population. This service, healthcare services, must have an adequate cascade and adequate linkage to prevention and care, and a cascade of friendly treatment with different services that are differentiated for adolescents. When we think about an adolescent that comes for healthcare, we may think about other problems, use of drugs. This may be sex worker, it may be a young man or woman, and also a pregnant woman. All of these groups require different approaches, and all of these groups require PrEP if the patient is not yet infected. And all these groups require the adequate use of condoms, and this also requires mitigation of damage, especially for drug addicts and particularly from intravenous drug addicts. If this was not achieved, it is important to guarantee access to treatment. To treatment that allows for adherence, the giving out of condoms, the control of STDs and other opportunistic infections, giving out comprehensive and clear information that allows the adolescent to understand, to decrease the stigma and discrimination, and to obtain a better social justice. All of this is ideal. This is a South American meta-analysis distinguishing a series of studies showing the low adherence, which goes from 66% to 33% in the worst of cases. So we know that this is a group with a low adherence to treatment. Therefore, services must be differentiated with strategies and interventions to support pregnant adolescents that live with HIV and to improve the maternal and child outcomes. Also improve results throughout the cascade of HIV, including peer interventions and psychosocial interventions to improve program results. And when we speak about treatment, we must consider an effective monitoring to improve adherence among adolescents and factors that impact their success, safety, efficacy, and acceptability of new systems of drug administration, and very importantly, the optimal sequenciation of antiretroviral therapy in adolescents, because we must remember that they will live throughout their whole lives with HIV. Our Latin American standards, which were written for all populations, includes the group of young male with difficulties in adherence, as occurs in the adolescent group, especially in those with higher viral loads, psychiatric diseases, etc. We have to divide young men in different groups that must not be treated in the same way, and it is important to individualize therapy in these groups. When we speak about youth and adolescents that obtained their disease at a young age, peripartum or through breastfeeding, we must speak about sanitary transition. This is when the adolescent goes from the pediatrician to the adult physician. This implies that there is less involvement of the family, a greater volume of patients, a different responsibility, and different approach from the healthcare worker. And this is an important point of inflection and change. Here we can see the difference in prevalence of complications in adolescents living with HIV and those not living with HIV. We can see that the deterioration of the system in HIV positive adolescents is different. For example, in case of more than one affected system, the deterioration is greater. This may have to do with mechanisms that push the immune activation from childhood to adolescence. And here we must consider factors such as antiretroviral toxicity, maternal factors, socioeconomic factors, environmental contamination, nutritional factors. With the absence of certain nutritional factors, the presence or absence of physical activity, all of this affecting the adolescent and the child and leading to immunologic activation and the activation of T lymphocytes. This makes the adolescent who is becoming an adult have activation of the immune factors that can be detected with biomarkers for each of the organ systems, the neurocognitive involvement, cardiovascular involvement, mineral bone problems, etc. All these factors are measurable and can be combated using these tools. Therefore, the adolescent who is becoming an adult or the adult who is living with HIV already has complications related to HIV and also comorbidities as occurs with renal dysfunction present in 30% of patients living with HIV, alterations in bone mineral density, presence of cancer which is not definitory of AIDS, cardiovascular disease, and neurocognitive dysfunction. This leads to causes of death not related to AIDS be different in the different scenarios. For example, if we speak about a developed country scenario, we have different diseases. Cardiovascular disease is the most frequent cause of death. In the case of patients living in developing countries, we have cardiovascular disease, cancer, and liver disease as the most common. And in African countries, we may have all factors and all causes of death not related to AIDS together. How do we reach these comorbidities? Mainly keeping a high viremia, low CD4s, which are situations associated to AIDS, constant inflammation, immunologic damage, the use of drugs such as efavirenz, tenofovir, INSTI, and protease inhibitors, late initiation and prolonged duration of treatment. This is a lifelong treatment, a greater burden of comorbidities exacerbated by smoking, lack of exercise, stress, poor diet. Uh, All of this makes the life expectancy in patients with and without HIV infection, as shown by the Kaiser Permanente cohort from 2000 to 2016, shows that patients living without HIV have a different life expectancy compared to patients living with HIV. So the gap is still present, mainly due to chronic diseases of the liver, of the kidney, of the lung, diabetes, cancer, and cardiovascular diseases. The most frequent diseases identified by Gallant in the 2017 study was hypertension, diabetes, and hyperlipidemia. These are the most frequent diseases. When we speak about liver disease in patients living with HIV as adults, the risk factors are non-fatty or fatty liver disease and non-alcoholic fatty liver disease, B hepatitis and C hepatitis infection, use of drugs, autoimmune diseases of the liver, and uh, frailty. The mechanisms are multiple: oxidative stress, mitochondrial lesions, lipotoxicity, cytotoxicity, with microbial translocation in the bowel, systemic inflammation, and leading finally to fibrosis, cirrhosis, and terminal diseases. We also have the problem of multi-cognitive disorders in patients living with HIV due to also use of drugs, alcohol, and polypharmacy. And we must also acknowledge that HIV is a neurotropic virus. All of this leads to multi-cognitive disorders in this population. When we speak about renal disease, we must acknowledge that there is co-infection with hepatitis, diabetes, hypertension, which finally lead to nephropathy associated to living with HIV, also immunocomplex deposit, chronic renal disease as pathways for renal disease associated to HIV. And finally, polypharmacy, where there is an increase of risk of death associated to polypharmacy, and the probabilities of polypharmacy presented by WOMAC in 2019 showed that there is a 19% of probabilities of using 5 additional medications not associated to antiretroviral therapy. This means that in the life cycle of the person living with HIV, poverty, genetics, race, smoking, poor education, use or misuse of substances, depression, trauma, social isolation, followed at an adult age with obesity, hypertension, dyslipidemia, diabetes, renal insufficiency can, in the late stages, lead to chronic diseases. I would not like to repeat what Dr. Posnick said about the average change in weight at week 48 in patients in initiating antiretroviral therapy. This average change in weight was also acknowledged in the studies shown in AIDS, 2020, and also the use of uh, Tegravir. It was shown that there are 1.85 times more frequency of having a higher BMI with rolutegravir compared to other antiretrovirals, and an average of 1 kilo of weight gain using rolutegravir. The recent studies confirm what was already known, and it has been acknowledged by the DHHS guidelines in the sense that weight gain should be considered, and the causes must be cleared. And at the time being, people who have problems such as a metabolic syndrome, hypertension, and diabetes should have more information derived from clinical studies. What are the interventions used to reduce the inflammation derived from HIV infection treated with antiretroviral therapy? First, avoid inadequate replication of the virus using optimized antiretroviral therapy, the avoidance of microbial translocation, for example, with rifaximin, improving T cell function, avoiding inflammation with statins, chloroquine, and others. And we also have anti-infectious specific treatment for opportunistic infections. When we speak of the elderly patient and HIV, we may say that there is a worsening of HIV. This has clearly to do with our workshop, with an increase in patients over 50 years of age living with HIV, as you can see in this graph. We know that there is an early aging of cells due to HIV infection, and this means that people living with HIV are older in a way or sicker in a way, and studies show that there is an accentuating aging with features that are similar to immunosenescence in patients over 70 years of age in those receiving antiretroviral therapy. This makes us require a model of care based on the 5 M's of geriatrics in patients living with HIV. But most importantly, we must individualize, as done by the DHHS guidelines, the therapy in patients that already have the manifestations I have mentioned. Antiretroviral therapy in patients over 50 years of age should ensure adherence. We do not know if we will suppress viral load, if we will increase CD4s, but we should know that comorbidities and the specific scenarios make people living with HIV require what we are already doing in Latin America in specific scenarios. Almost all Latin American countries are changing their guidelines to individualization of therapy in these specific patients with comorbidities older than 50 years of age, patients with other infections with a high cardiovascular risk, dyslipidemia. They have specific therapies that cannot be one for all. We have standard recommendations for late presentation, pregnancy, women, patients over 50 years of age, and we also have in the American guidelines, the EACS guidelines, the same idea. Around the world in general today, the trend is toward individualized therapy. And just a minute to speak about the key studies for dual therapy that can go very well in this group, both for initial and for maintenance therapy, as described in the CCO slide. All of the clinical studies about initial or maintenance antiretroviral therapy using dual therapy. This achieved a reduction of at least one of the markers that I've mentioned previously in this multivariate logistic regression analysis. So we must consider dual therapy in this group of people, of patients. And finally, we should change antiretroviral therapy in patients with adverse events, something that may be delayed in Latin America. We should immediately suspend if there are severe events when toxicity does not risk life. We can suspend the supposed causal agent, and if there are non-life-threatening events, we can substitute the suspected agent. We should pass these guidelines to reality, trying to adjust therapy in our patients. And all of this has been a quick review in these two groups, adolescents and elderly patients. Thank you very much.
Muy bien, muchísimas gracias, doctora Ana Paulina Celi, por la.
Thank you, Dr. Ana Paulina Celis, for this presentation. We have now time for questions. We want the panel to be available for this Q&A session before we end this day. First of all, for Carlos Beltran, a question regarding if there is any difference about the percentage of people living with HIV diagnosed between countries, depending on the policies, opt-in or opt-out policies. Carlos, please, what are your thoughts about this?
The opt-in and opt-out refers to the confirmed consent or dissent previous to the HIV testing. I think that some countries, they have discussed that at length, but I will ask Maria Marta, there are some places where they have this opt-in and opt-out mechanisms. No, in fact, the informed consent to accept the test, to accept the HIV test, is the rule in most of the countries in our region. The opt-out, practically in Latin American countries, has not been incorporated. And this is related to old laws that are still in effect. Maria Marta, there's a question that is about the vaccines. When the time comes, will they vaccinate people living with HIV against SARS-CoV-2 or not? So what will happen with people living with HIV? What would be the context of people living with HIV that would be vaccinated against SARS-CoV-2? The truth is that we have not included HIV patients in most of the vaccine studies and trials. Therefore, the regulations for that are not in place yet. Well, they need to get the vaccine, and it's not clear yet whether they are more vulnerable or not. At the beginning of the pandemic, most of the reports pointed at the fact that they were not patients that would be more impacted or would be more hospitalized or will require intensive therapy, but in the series of cases that are more recent, there's controversial information. Therefore, there will be patients that would need to be vaccinated, but we have no clear data on that front in most of the countries. And those patients were not included in most of the trials, and they should have been people living with HIV. In Chile, the regulations from the Institute of Public Health for the Pfizer vaccine has just been published. Apparently, the last week of December, the vaccination will begin. First, the healthcare professionals, and it excludes pregnant women, those people under the age of 16, or immunodepressed people, but people with HIV, chronic HIV, controlled HIV, and normal viral load can be vaccinated. I have no doubt that they will be vaccinated. We, I think that this is a question worth actually contemplating with what type of adenovirus or deactivated RNA, what type of vaccine you would prefer. But I do think that this is a reality. And patients that are controlled for HIV are patients that, because of other conditions, such as obesity, comorbidities, do have a higher risk of developing a severe form of the disease. So we will continue with other questions. One question from a distinguished colleague whose name I will not mention, from the north of Chile, a personal friend of mine. He asked about what Dr. Greco said about telemedicine, because we have the impression that it has taken the limelight, and maybe most of our patients can't be cared for by telemedicine, regardless of the COVID pandemic. My question for Dr. Greco: what was the experience like at your center of telemedicine? How much time did you devote to each patient compared to the traditional method? What platform did you use, and what would you recommend for the future? The truth is that we had a lot of experience with telemedicine. We used basically Zoom or just calls, video WhatsApp calls. I live in the city of La Plata, which is the capital of the province of Buenos Aires, and we saw many people. We usually care for many people living very far away from our center. And during the pandemic, they were not able to come to in person visits. So we did use the WhatsApp video calls or the Zoom platform. We would send the prescriptions to them. There was a decree that allowed that in our country. So we sent them a photograph of the prescription, and that was accepted by the pharmacies and by the social security organizations and healthcare insurance. So were able to do that at a distance. It was fundamental for those people, and to be able to adhere to their treatment and continue with their checkups. Of course, it's a group of patients that must be stable already with good CD4 count and who are practically healthy, because there are other types of consultations that require you to be face to face. And in those cases, in my country, according to the regulation, we could give them a special permit. They could get a special permit to be able to come to the center. Exceptionally, they would then be able to come to us. But the telemedicine, I think, is here to stay. I think it's a supplement to in-person care. It does not replace it by any means. It is merely a supplement for a subgroup of patients that is far away from the centers, and that this increases access and probably adherence, because they will not have to move and travel long distances. But it's not for everyone. It's not a replacement. It will be a supplement. That is my humble opinion. I would like to mention an experience. We installed a platform for telemedicine for COVID with the support of the private sector. We took care of 55,000 patients. Then it became the platform of the keto department, and it was very helpful during the pandemic because although we didn't have any authorization to prescribe, the fact of being able to see our patients and be able to give them an idea of where to go, it was very helpful. This initiative will be ending next week because it was only until December. I'm very sad about that because I think it would be very wise to continue with it because it was very helpful. We're under the impression, Ana Paulina, that telemedicine is a tool that we can dispose of for an important group of patients. Telemedicine in the setting of HIV patients is very helpful without a doubt. And there are several questions. We have one.
Esto va un poco
This is addressed to Maria Marta, Dr. Greco. What happened with the HIV prevention campaigns in this area of the pandemic in the region? What has happened? Has this been totally stopped by COVID? Well, most of the reports speak about a decrease at all levels, decrease in testing, decrease in prevention, both in the countries that have included the PrEP, and post-exposure prophylaxis. All of that has decreased at all levels, according to the reports. And they have resumed their activity. Dr. Andrea Gonzalez spoke of the experience in Mexico. And even in Mexico, where they have so many mechanisms for testing and prevention, even despite that, the lockdown decreased all of those. And so at the regional level, all the services have declined. Treatment is the less impacted item, according to UNAIDS recent report. So treatment was the least affected, and the most impacted area was testing and prevention. One question for Dr. Ana Paulina Celi. During your talk, you spoke about patients under the age of 25, and you mentioned a piece of information that was extremely important, that there was a missed part of the population of young people in Ecuador and Venezuela. What happens with that? Well, we have an epidemic of very young people, but we have a problem as regards prevention, basically. In that young population, they have a decreased perception of risk, an increase of alcohol consumption, and also an increase of drug use. We don't have IV drug use, but the use of crack cocaine and cocaine, and even some homemade products have been used for drug use. So we have a serious problem in our young population because they begin to do this type of practices that diminishes the risk perception that they have. So we think that basically there's a lack of awareness from the family about the activities that the young people engage in. It's important to take into account that what happens in Chile, what happens in Ecuador, the Ecuadorian family has many restrictions, but those restrictions are usually applied outside the home. But there's a difference in between what the teenagers do, what the young people do, and what their parents know that they do. So I think we need to work on that. And also the beginning of sexual intercourse. That is a very serious issue in Venezuela. Initial intercourse, I mean the beginning of intercourse, and the number of different partners, sexual partners. It's very much accepted in Ecuador, where it's a very widespread type of practice, especially in men, and that's made this be a worse epidemic in young people. It's very interesting. There are several questions that have not been answered, but in the interest of time, I would like to close by asking a question for each of the panel members. The COVID-19 epidemic, what it has done, in my opinion, is to reveal the differences existing in access and in the social economic level of people who become infected with HIV compared to people who are infected in the rich areas and in the poor areas. This happens in cities in Mexico, Argentina, Ecuador, without a doubt. And what you mentioned also, Ana Paulina, about the SDGs, the Sustainable Development Goals, and this is something that's quite related. So now, leaving medicine, the topic of medicine, what is your opinion on the real final solution? That at the end of the day, it seems far more important for someone to have education, access to water, and access to health than all the other issues we have been discussing, sometimes from a scientific point of view. I would like to ask each of you for your own opinions on this topic. Well, as regards that topic, I think what COVID did was reveal the healthcare system, the weaknesses, but it did show some of the strengths in our system too. In a previous meeting, I had presented what the strengths were in Uruguay. And in Uruguay, for instance, there had a primary health care that was very good before the pandemic. So that shows that if you have primary care centers, widespread and good, with a good response capacity, that is a very good thing to have for any epidemic or pandemic, COVID or HIV. But then to take everything to the third level is not always the best solution. We need intensive care units, but we also need things such as access for young people to condoms on a free basis, and also for them to have friendly settings where they can go. So I think we need to begin working sideways and stop just thinking about our position inside the hospitals. That is valuable, but it's not everything. I agree with Ana Paulina that making comprehensive care and primary care, providing a more holistic view of this from the social, cultural, and economic points of view. I can't speak of adherence to a woman who doesn't manage to make it to the end of the month and feed her family. How can I speak to her about adherence or the drugs she must take if she lost her job, or someone who lost her job and must support her family? It must be a more holistic view. And primary health care is able to decentralize testing and prevention and even treatment, and it's capable of generating this comprehensive view of health that is a more environmental, biological, and social way of looking at health. And I think that the solutions must come from that side, that approach. But again, that's my personal opinion. I would like to simply say what I showed in that slide about the 2025 goals. Beyond the fact that people say that we want to reach 95, 95, 95 in 2025 instead of 2030, I think that is basically wishful thinking. I think that if we didn't get close to 90 in 2020, it's actually not really feasible to say that we'll get to 95 in 2025, which is like shifting that goal, that deadline. I don't think it's feasible, but that 10% of inequity and stigma I think that what should be the center of all this is focused on people living with HIV and at risk of acquiring HIV. I think that is key, and it has a lot to do with what you spoke about in primary health care. Because when we talk about prevention, we're talking about people, we're not talking about patients. And anything that has to do with prevention has a very strong community foundation. I don't mean to look down on the tertiary healthcare because there has been a great progress in that remote treatment and the way of dispensing the medication. I think that's important, but to add a community focus where we give access to 90%, but not 90% of people, because that's our greatest issue. We're controlling 60%, if we're lucky, of people living with HIV, and much less of people who are at risk of becoming infected with HIV. So if we manage to connect these people so that we can do true prevention, I think that it would be possible to move forward as regards these goals. And I think that's a message that has been so well put by Martin, that in Latin America, we are going in the opposite direction as the rest of the world, because the world might be not successfully on the right track, but they are moving on the right track. Because in the past, we used to fight with the people in WHO when we said that there were higher numbers of newly infected people in the young people. They said that no, that wasn't the case, but it is undeniable. This contagion is increasing in young people, and young people are clearly not having access to prevention. I mean, young people with HIV and those young people who are at risk of acquiring HIV. So I think that should be the message. And I ask you, Martin, when you wrap up, to invite everyone for tomorrow, because tomorrow we will have some very interesting and enlightening topics, and it was really necessary to talk about HIV again. I think it was too bad that we had to devote 90% of our attention to COVID and leaving HIV on standby, and the cost of that will be paid later, I think. Thank you, Carlos. Thank you so much, Ana Paulina and Maria Marta and Andrea, for your presentations. It's been a true source of satisfaction and enlightenment from a scientific point of view, and also from your opinions that are very much appreciated and very valuable. I would like to apologize to Susana, Kitsu, and Ignacio because we were not able to answer your questions. I think they were partially answered, and I would like to also say that many of us have lost a close friend because of the epidemic. So it's always important to mention that we are all affected by the situation, and that we need to cheer each other on and applaud and salute the work that we have been doing, selfless work without expecting anything in exchange. Thank you to everyone. I thank you to the panel members. And as Carlos said, tomorrow there's an extremely interesting program awaiting us in this workshop. And I would like to ask you if you please can open, I'm not the host, I don't know what to call him, but maybe the person who is hosting, can you please turn on the camera so we can take a screenshot? Please, can you do that? That would be very nice.
Bueno, buenas noches a todos.
Good night, everyone. Good evening. Good evening. See you tomorrow. Goodbye. See you soon. See you tomorrow. Bye-bye.
Dovato, un salto a la nueva era.
Dovato, a leap to a new era in the treatment of people living with HIV. A powerful combination of two drugs in fixed doses available in the world and now in Chile, Dovato, with the efficacy and long-lasting effect of dolutegravir, high barrier to resistance with zero resistance mutation compared to a 3-drug regimen without TDF, TAF, ABC. So it's one single pill based on 2 drugs.
El compromiso de Gilead por una eventual
Gilead's commitment for the future eradication of HIV has been firm. We have been contributing with effective drugs that have become much simpler to take, much easier to tolerate, and safer in the long run. Therefore, HIV has become a chronic treatable disease. In Latin America, more and more patients have access to our innovative therapies that save lives and improve their quality of life. Our commitment is permanent, and we still have a long way ahead of us, but it is in our hands to make it possible and succeed. We need to make this possible and not only manage to have our patients be undetectable, but also for them to reach a full state of health and well-being.